Good afternoon, everyone, and welcome to our All Access Iowa event titled Let's Talk Mental Health in a Pandemic. My name is Lynette Marshall, and I have the privilege of serving as President and CEO of the University of Iowa Center for Advancement, and we're delighted that all of you can join us this afternoon for this important event. I have just a few housekeeping things before we begin. For all of our attendees, your cameras and sound are turned off. And I also want to let you know that we are recording today's discussion and closed captioning is available. If you want to access that closed captioning, click the CC icon at the bottom of your screen. You may experience a slight delay if we have heavy Zoom traffic, so we apologize in advance if that occurs. After hearing from our distinguished panelists today, you will have the opportunity to send questions and can do so anonymously if you wish through the Q&A function at the bottom of the screen. We will try to get through as many of those questions as possible. And while today's session is intended to be informational, you of course understand that our panelists cannot provide health or medical advice during this virtual event. So today's topic covers mental health in a pandemic. And we know that underlying mental health disorders have certainly been exacerbated during the pandemic and have been felt across the nation as well as here in Iowa. That's why I'm glad that we are joined today by a panel of medical experts from University of Iowa Healthcare who are at the forefront of mental health education, research, and patient care. Joining me today are Dr. Peggy Nopoulos, the Paul W. Penningroth Chair and Departmental Executive Officer of the Department of Psychiatry, Dr. Allison Lynch, Clinical Professor of Psychiatry and Family Medicine and Director of Addiction Medicine and the Opioid Addiction Clinic, and Dr. Hannah Stevens, the Ida P. Holler Chair and Director of the Division of Child and Adolescent Psychiatry. Thanks to each of you for being with us today. And Dr. Nopoulos, would you care to start us off?
You bet. Thank you so much for that introduction, Lynette. And welcome to everybody who's on. Just a brief overview of our department. So the Department of Psychiatry, we just had our 100th year anniversary recently, because we were founded in 1919. We are comprised of about 85 faculty, and that includes MDs, MD PhDs, and PhDs. And then we have a whole variety of other what we call providers that round out our mental health workforce: physician assistants, nurse practitioners, and social workers. And we're a hospital, so we have 77 mental health inpatient beds. And we have per year 26,000 inpatient days. So we're a very busy service. We are always full. And I think it's one of the issues that we have going forward is making sure that we're able to serve everybody. Our outpatient services are very busy. So we have a child psychiatry division that you'll hear from later on, and that serves 12,500 visits per year. Our adult clinic serves 28,000. And addictions, this is actually probably an old number, 8,000 visits per year. That's gone up substantially. I think importantly to remind everybody, we serve all of Iowa. So the little graphic here, the state of Iowa, each one of those blobs is a zip code. And the lighter colors are lower numbers, the darker colors are higher numbers. But you can see, obviously, we pull people from Eastern Iowa heavily. But we do try to serve all of Iowa. So we do quite a bit of serving, although there's bare areas there and we could do better. Next slide. So I think what's important to set the stage is that prior to the pandemic, mental health was already in somewhat of a crisis. And that is, we have had a very substantial increase in the past couple decades with what we call deaths of despair, which is drug, alcohol, suicide mortality. And this is a graph with the red line showing what are the white non-Hispanics in the United States. And you can see the inflection point from 2000 going up and up and up. And once again, this was before the pandemic. And so these quotes are important. We have never seen demand for psychiatrists this high in our 30-year history. Demand for mental health services has exploded while the number of psychiatrists have not kept pace. By 2025, we expect the US to be short by 16,000 psychiatrists. So Merritt Hawkins is a recruitment firm. And just to set the stage for the fact that before the pandemic, we were already undergoing a lot of pressure. Next slide. But as the pandemic has ramped up, there has been a lot of pressure. And as pressure is on everybody, but really important to emphasize too, unfortunately, as we saw in terms of just COVID exposure and COVID infection, mental health is also disproportionate in the Black and Latinx communities as well. So if you look here at just some of these numbers, where we look at the essentially rate of some of these disorders, if you look on the right side, anxiety disorders, and I'm sorry, I think these numbers got a little bit off in the columns, but anxiety disorder at 8.1% in June of 2019, but up to 25.5% in June of 2020. Depressive disorder, 6.5% in June of 19, up to 24.3% in 2020. Suicidal thoughts, 4.3% in June of 19, up to 10.7%. So once again, these stressors, psychological stressors that increase people who already have a mental health disorder or those who haven't had one that develop one, it's across the board, but in particular, it also affects disproportionately underrepresented minorities as well. Next slide. So next bullet point. So the things that we're going to touch on today are important because these are really the points that I think that we've seen extra hot topics on. So things that were problematic before the pandemic, but with the pandemic really took a major step up. And definitely one of those is substance use across the board. And that's what Dr. Lynch is going to be talking to us about. So very important. Next bullet, children and adolescents. Really unique situation in the pandemic. And just in terms of families and children in the context of school. And we've never seen this kind of pressure. And so in particular, the pressures on children and adolescents has been particularly severe. Next slide, next point. And I'm going to talk specifically about our emergency room crisis because this is a very primary issue for us. This is not unique to Iowa. This is absolutely nationwide. But there is a lack of community facilities to care for those with serious mental illness, and in particular, dementia as well, which is becoming more and more common. There's also a lack of facilities for substance abuse treatment. And as I've mentioned before, our mental health beds are always full. Okay, our capacity is very high. So what happens when we have the pandemic, when we have increased stressors, when we have increased numbers of people who are needing our help, and in particular, if they are in crisis, they come to the emergency room and they often get stuck there. It's a system issue. So the emergency room, doctors, nurses, and social workers, in general, it's not a place where they're trained to provide mental health. Some facilities have very specific separate ERs for mental health. We don't have that yet. I'll talk about that. But what happens is that our patients in the emergency room often get stuck there and they have to wait. And oftentimes, if they need a mental health bed, they are there in the emergency room, sometimes for days at a time. Next slide. So this is just a picture of what that process looks like. Everybody in the emergency room is doing their best to serve all the patients there. Sometimes our patients that get stuck there are literally in the hallways just because it's such a busy place. And we're trying our best to serve everybody. But what we did just a few years ago to address this problem specifically is we opened up a crisis stabilization unit. So that's called our CSU. You see a picture here of Jody Tate. So she's our vice chair for clinical services. This was her brainchild, her work, her blood, sweat, and tears, I'll be honest with you. So the hospital was wonderfully supportive in being able to identify a space in the hospital and renovate it to look like this. As you can see the difference between what would be like in a hallway, an emergency room, and this facility. This opened up in October of 2018. And the next picture will just show you again what a really beautiful place it is and what a different environment it is. This allows us, when people are in crisis, to do active treatment. So these are nurses and social workers and doctors who are in the moment being able to treat these patients. Many of them, after 24 or 48 hours, can go home. Some of them get hospitalized, but this is a really whole new development in the way we treat people in crisis. Next slide. I'm going to have you go through. So initially we had help from the CSU, because I mentioned that opened in October of 2018. But from the pressure of the pandemic, we're back again to the same issue. At any one time in the emergency room, mental health patients are 25 to 40% of that population. Children in the emergency room are particularly affected. And so I'm just showing you this slide here, and that yellow arrow, you can see the dotted line is 2020. So you can see the effects and the timing of the increase of the number of children that are coming to our emergency room in crisis. And at this point, the CSU that we developed is for adults only. Next slide. So our solution that we're working on is having a full emergency room that is specific for mental health. This would serve children and adults alike. It would be CSU for adults and children, in addition to other ER beds. This is something that we're working closely with our hospital on. And once again, it would include all sorts of mental health professionals, but specifically being able to take care of this population and get them treated and where they need to be as soon as possible. So that's one of our primary issues. I'm going to hand it over to Dr. Lynch now. So Dr. Allison Lynch, you heard about her. She is the director of our addiction services. She's dually trained in family medicine and psychiatry, and she's going to tell you about the stressors that people have had regarding substance use. Dr. Lynch.
Okay, thank you. So we're just going to look back in the rearview mirror and look at kind of some trends in substance use prior to the pandemic. So overall in the United States, substance use before the pandemic was pretty stable. Cigarette smoking and alcohol use were trending down. Marijuana use was increasing, and vaping was new and then up. And there was also an increase in inhalant use among teenagers, 12 to 17. And then looking at Iowa specifically, Iowa has had very high, very much more than the average across the US rates of binge drinking. And methamphetamine has been going up in Iowa over the past 10 years. And like the rest of the nation, we've been dealing with an opioid crisis that has been the source of overdose deaths and increased rates of hepatitis C. And just talking about the opioid crisis nationally, there's about 2 million Americans who have a diagnosis of an opioid use disorder. Fentanyl has been contaminating the opioid drug supply and is responsible for a lot of the opioid overdose deaths. And these deaths, the number of deaths per year peaked in 2017 and actually went down slightly in 2018. So that's before the pandemic. So we can go to the next slide. This is just a picture, just a graph to show you from a national survey that's done annually, asking about alcohol use in the past month and illicit drug use in the past year. These rates had been stable over the past, the graph on the left is about 15 years worth of data, and the one on the right is about 5 years worth of data. So these trends had been fairly stable. Okay, we can go to the next slide. And I don't have a graph for 2020, but we are getting a lot more information about that. And I think we're going to see that the direction of the graphs goes up. When COVID hit, we know that alcohol sales went up. In fact, they went up about I think 10% over the whole year of 2020, but compare December 2020 compared to December 2019, alcohol sales were up 20%. So a big jump in alcohol sales. drug availability also went down and changed. And I'll just compare this to, if you remember at the beginning of the pandemic, the commodities that we all depend on, food, toilet paper, gasoline, all of those things were suddenly in either short supply, or you had to get them in different ways, or you had to pay more for them, or you just had to worry about where you were going to get them. And that impacted the drug supply as well. Border closing, global trade declining and changing, stay-at-home orders, all of those impacted people's access to substances that they may be dependent upon. Prices changed, and we noticed that drugs that were produced locally, such as cannabis, were less impacted by some of those supply chain issues than drugs that are generally transferred through the global supply chains like cocaine and heroin. We also know that during the pandemic, the amount of fentanyl contamination in the drug supply has increased. And prior to the pandemic, fentanyl was a problem in the heroin and opioid drug supply, but now we're seeing more and more fentanyl contamination in other drugs such as methamphetamine and cocaine. And that's important because fentanyl is a large contributor to the overdose death rates that we see. We also know that people reported increased use of having to share or reuse needles if they were injecting drugs, which puts them at higher risk of having an infection associated with their drug use. Okay, so we can go to the next slide. So pretty early on, we were detecting people reporting increased use of substances. By the summer of 2020, people were saying they were using more substances specifically to cope with the stress of the pandemic or emotions related to that, fear and anxiety. And we do know that alcohol consumption quickly picked up during the pandemic as it started. On the right are just 8 different reasons that people who reported increased marijuana use during with the beginning of the pandemic, the reasons that they identified for smoking more or using more marijuana. Either they were lonely, they had more free time on their hands, they were home more, and it was something to do at home. Many people tried because they were worried about access to their substances that they are dependent on, stocked up at the beginning. So then they had a larger supply at home. And so some people identified that that was a reason. Depression, lots of reasons identified for why people were increasing their substance use at this time. Okay. So this graph is just to illustrate the impact of the opioid epidemic on in the US. It's a problem globally. You can see from the graph at the top, that linear graph, overdose deaths related to opioids had been increasing up until they peaked in 2018. They went down in 2019 slightly. I have this backwards. They went up, they peaked in 2017, they went down slightly in 2018, and then in 2019, they were going up again. And so in the middle of 2020, we found out that we had the data for 2019. And in fact, even before the pandemic started, the number of people who died from an opioid-related overdose in the US went back up. So that it was already starting to peak again. And then you can see at the far right of that linear graph, we are just seeing escalation in that graph. And right now we are on track to have over 90,000 deaths in 2020 due to opioid overdose death. And I'll tell you, I looked at this like 2 or 3 weeks ago, and at that point we were on track to have over 80,000, which that would have been a new record. But now it looks like we're going to have over 90,000 people who die in 2020 due to an overdose death. So the map at the bottom is just intended to show the states that have an increase in overdose deaths in the past 12 months. There's one state left that does not have an increase in overdose deaths, and that is South Dakota. Every other state has more overdose deaths in 2020 than they did in 2019. So big problem. We are not done with this opioid epidemic. As far as the impact of the pandemic on treatment for substance use disorders, we all have had to deal with social distancing, and it's challenging under the best of circumstances, but it really created a lot of challenges for people who were trying to get into or continue in any kind of a treatment or recovery program. Isolation and loneliness can often fuel worsening of a substance use disorder or just substance use in general. And it led to not having that in-person support from other people that can be so important for recovery. Mutual support groups like AA or NA, those meetings previously were in person, and that was for many people a very important foundation of their recovery support system. Those meetings shut down. Many of them moved online, but for many people that's not the same thing. A lot of clinics had to at least temporarily close, treatment programs closed or cut down on the number of people that they could treat at once in order to maintain social distancing. Access to prescription medications, and in particular, controlled substance prescription medications, which is what we use to treat opioid use disorder, the system for people to access those medications changed. And for many people, it was harder to access medications, at least initially. And then just remember, in the background, we have the stress of the pandemic. Many people lost their job and they're worried about getting the virus. So it was an extremely challenging time for people who have a substance use disorder. Okay. So what did we do at UIHC? And a lot of this is what our healthcare system has done across the world to respond to this situation. We did a quick pivot to telehealth. Initially, so we never closed our clinics. We went first to phone call visits, and then within a week or two, we had video visits enabled, and we were given the green light to actually use those clinically. And so we switched over and have been doing telehealth visits via video since then for all of our psychiatry clinics, including our addiction clinic. In July, we surveyed about 150 patients who come to our addiction clinic and asked them a whole lot of information about their experience with the pandemic and also accessing their care during the pandemic. And it turns out our patients actually really like telehealth for a number of reasons. They didn't have to worry about contracting the virus because they could just do their visit from home. They didn't have to commute. They didn't have to find a ride. They didn't have to pay for parking or for gas. Just a lot of convenience issues. So that's been a good thing. Another thing that happened early on was a lot of substance use treatment is done in groups, and many groups paused for a little while and then switched to Zoom, which allowed treatment to continue. But again, Zoom and doing video interactions isn't the same as in person, and for some people, it's not as helpful. We saw an increase in referrals to our addiction program at the beginning of the pandemic. We continued to be prescribed medications for treatment and recovery, including a medication called buprenorphine, which is what we use to treat opioid use disorder. And there were a lot of agreements and organization and coordination in the background by many organizations and agencies in the federal government and state government that allowed us to suddenly be able to prescribe buprenorphine through video visits, and actually to be able to do video visits to somebody's home even. So there's a tremendous amount of coordination in the background that enabled us to make this pivot pretty quickly. Okay, next slide. So as far as how people who have addiction issues or substance use disorder have been impacted by the pandemic, they are a very vulnerable population. We know that people who have a substance use disorder are more likely to get COVID-19. And we also know that when they get COVID-19, they're more likely to have severe illness, hospitalization, and even death. Okay. So next slide. So where do we go from here? We really need to push to maintain increased access to treatment and recovery services. And telehealth has, in some ways, been a real positive thing to come out of the pandemic because it has made access to treatment easier for people. We need to continue that. We need to encourage everybody, especially people with increased vulnerability, like people who have a substance use disorder, to get vaccinated against the virus. And we really need to continue to focus our efforts on ending the opioid epidemic. Fentanyl is a problem throughout the drug supply now. Naloxone is a medication that can be used to rescue somebody who's had an overdose, and we need to get that out and available, easy to access. And we need to have more access to evidence-based substance use treatment. The last thing I'll say is we also need to address stigma. Stigma is a huge reason why many people don't get help or treatment for substance use disorders, because they may have had a bad experience in the past, or they may be ashamed. And until we address stigma, we are going to continue to have too many people who don't get treatment. So with that, I'm going to transfer the baton over to my colleague, Dr. Hannah Stevens. Dr. Stevens is the director of the Child and Adolescent Psychiatry Division within the Department of Psychiatry. She runs the Psychiatry and Early Neurobiological Development Lab at the University of Iowa Carver College of Medicine, and she studies early brain development, especially the impact of prenatal stress, environmental exposures, and genes on the development of psychiatric disorders. So I'm going to let Hannah take it from there.
Thank you so much, Dr. Lynch. All the work you've been doing is so impressive. So many efforts went into everything that happened and all the vision that you have about where you're going in the future, which we hope is what we also have in child psychiatry, a vision for the future. So I want to just touch a little bit on what has been happening for youth and their mental health during this pandemic. And it may not be that you need to hear this from me, because I think it's become part of our, unfortunately, broad cultural knowledge that children have been dramatically affected. The really positive thing is that children don't get very, very sick from this virus, unlike flu epidemics in the past. However, that doesn't mean that they're not affected. One of the pieces of data that's just beginning to come out that was published just last month in the journal Pediatrics showed that the more going on in a community with COVID-related stressors and community responses to the virus, the more high rates of suicide-related behaviors happened in youth during these time points. So if you think about how we've been on a roller coaster over this past year with things going up and things going down, and maybe never really going down, entering a period of relative control of the virus, but youth still feel the impact of the uncertainty and the changes in their routines. So what happens to youth and why are they affected this way? Well, their school environments have dramatically been affected. Schools going to virtual only, learning from home, hybrid conditions, especially for youth that need to receive special education services, which aren't really tried and true in the virtual domain, have really suffered for having these environments disruptive. It's not just for academics that these are affecting youth. It's really affecting their socialization, which is, this is where children have their friends. This is where youth have their mentors. This is where they have adults to help guide them through many of the difficult things that they have to think about. And, there's been a disruption to all of our lives in terms of the kind of, celebrations we have to acknowledge transitions. We haven't been able to do things around graduations, birthdays. So you could sort of say everybody's affected by this, but you know how much more meaning these things have for younger people. They haven't had as many of these celebrations. They haven't had as many of these transitions. And there's just so much meaning placed on those things. And the fact that they haven't been able to happen has been very difficult for you. The family stress of unemployment from lockdowns and pandemic-related changes in our communities have been very, very hard on youth. Children don't always understand what happens to their family members when they lose a job or they're out of work or they're having more stress at job or they have to do things differently, but they can feel the sense of stress that parents and other family members bring home. And those parents and other family members are not only having to deal with their own stress, but they're having to try to help their children with virtual schooling, which has been a huge pressure on so many families and something we have basically talked about with almost every patient we've seen over this past year multiple times about how difficult this has been. And then, of course, many children have experienced the illness or death of family members from COVID-19, which can never be understated, overstated how critical that can be. And then, children, one of their developmental stages is to become more socialized, to learn how to act around other people, their peers, their older peers, their adults in their lives. And the socialization has really changed how children are able to do the normal stages of development. And all of this has led in many ways to children's mental health being very impacted, levels of depression and anxiety going up, and even in youth populations, we have increased levels of substance use, even with the changes in their socialization. So it's very serious and it has caused a lot of issues. And we tried to do a number of different things over this past year to try to benefit the children and youth that we serve. And I'm going to just share a couple of them with you today. So here I'm showing you a couple programs that we developed over this past year. fortunately, from some of our creative thinkers that work in our child and adolescent psychiatry division. So one of the amazing things that happened very early in the pandemic, when many of the healthcare providers were under huge amounts of stress and their families were experiencing that stress secondarily, Dr. Kelly Belzell coordinated a program for employees of the University of Iowa Healthcare who had young children, and brought those families together virtually in a way to support young children's engagement. As we talked about, the developmental stages for children are in the social domain, and help them develop more self-regulation skills in partnership with their parent. 145 children and their parents participated from the University of Iowa, and there was much positive feedback given to Dr. Pelzel about what a great and very timely intervention this was in the heart of that time when healthcare workers were being asked to do just heroic things in terms of learning new routines, having to cope with a disease they didn't understand in terms of COVID coming to the hospital. So that was an amazing program and really showed us that we can even reach out to very young children in that virtual domain. We also reached out to families through many of our child psychologists who work with families a great deal in the clinic about how to help, how parents could help their youth during quarantine, and in specific, not only with the changes of quarantine, but with other kinds of pandemic stress that were coming along. So there were multiple webinars and interviews with the press that went out into the public domain to help guide parents in thinking about how do I help my youth. And then we also made some clinical advances specifically to target the emergency room. As Dr. Nopoulos was saying, this was a major crisis point as the pandemic progressed, and still is, as of today. And we've tried to make our access to certain kinds of care easier to get down in the emergency room, so that we can start, even if children have to wait in the emergency room and get stuck there, we can start the healing process early. And we've developed here at the University of Iowa an amazing program for adolescents based on a kind of therapy called dialectic behavior therapy, which helps with developing emotion regulation skills, which is oftentimes what goes wrong in individuals undergoing a lot of stress, especially during that adolescent time period when emotional regulation is already a challenge. So I want to show you a brief video that was made here at the University of Iowa to help get access to those introductions to these dialectic behavior therapy interventions for individuals sitting in the emergency room and their families. Next slide.
Hi, my name is James Burkholder. I'm a social worker here at the hospital, and I work in the Department of Psychiatry. I imagine that if you're watching this video, things are not going exactly how you would like them to be going. I'm really sorry things are crummy, and I'm glad that you're here. I want to talk to you about a program called Dialectical Behavior Therapy, or DBT. It's a program that was created by a brilliant psychologist by the name of Marsha Linehan, and it's designed to help people be more effective at managing their emotions. I'm thinking someone in our emergency department provided you a little booklet about DBT, and I would like to briefly go over it with you. The handbook that was provided to you is the same thing that we use on our inpatient psychiatry unit for kids. We thought you might as well have access to this while you're waiting down here, regardless if you were admitted to this hospital, somewhere else, or if you were not admitted at all. I'm going to briefly talk to you about some of the basics of DBT, and then you can hopefully learn more by reading the materials that were provided to you. DBT stands for Dialectical Behavior Therapy, and it is a treatment program for adolescents and adults that is supported by a ton of research. Let's break down each of these words. Dialectical means two opposing ideas can be true at the same time. You can be super annoyed about being in our emergency department and also acknowledge that this may be helpful for you. You can be really frustrated about how things are going in your life right now and also be hopeful that things will get better. Viewing things from a dialectical perspective helps us get out of black and white and all or nothing thinking. It allows us to see shades of gray and potentially open up space that we have never explored before. Behavior in dialectical behavior therapy refers to possibly changing your behaviors. Intense emotions often cause people to respond in problematic ways that interfere with their goals. In DBT, we try to replace these maladaptive behaviors with more skillful responses so that we can get closer to living the life that we want. Lastly, therapy is the treatment of a disorder or a problem. We're going to try and teach you evidence-based strategies that will allow you to treat and solve your problems. There are 4 main sets of skills in our program. This includes mindfulness, distress tolerance skills, emotion regulation strategies, and interpersonal effectiveness techniques.
So that gives you just a brief overview of what we can start to do with youth, even sitting in the emergency room. And hopefully we can go back to the last slide. I'm not sure. There we go. Great. And we hope to continue to increase access to that using videos like this, which are more accessible to young people in the animated form, but give that kind of brief intervention in a really hopefully helpful way. But what we're planning for the future now is to do even more to combat some of the problems we found. We really have seen a huge crunch of needed care options for youth, and there not being options out there. So we need to train more therapists, and we need to build the pipeline for new people interested in going into mental health. So we have plans to outreach to undergraduate students to start building their interest in mental health as a career. And we're going to increase our presence in the emergency room to help connect youth to services. And we want to provide people with other ways of support that can come through virtual domains so that we don't have to all gather to learn some of the things that can help us with our mental health. So our fellows in our child psychiatry program created a podcast that can deliver education about common problems in mental health to youth and families in small bite-sized pieces. And then schools are really critical, as we've all seen, for keeping kids' mental health good. And we have people in our division working with nationwide collaborations to develop school-based strategies to really improve mental health interventions and improve responses to concerns based in schools, where we can really reach every single child. Thanks so much for listening.
Thanks so much, Dr. Stevens. And thank you also to Dr. Lynch and Dr. Nopoulos. We are really grateful to have had the opportunity to have an insight into what you have seen over the past several months and the real challenges that you're facing in trying to meet the needs of so many people who are struggling. We're all accustomed to hearing about the physical ramifications of COVID-19, but just as was true pre-pandemic, it's clear that we need to shift more attention and resources to mental health treatment and research. And we appreciate your insight on this important topic, and we appreciate what you do clinically in our community as well. I know that several of our listeners likely have questions. So remember, if you have a question for any of our panelists, please submit it by using the Q&A button at the bottom of your screen. And Dr. Nopoulos is monitoring this, and we will try to get through as many questions as we can. We're going to start with a question for Dr. Nopoulos. How has telepsychiatry played a role in helping people access care over this past year?
So Dr. Lynch touched on this, but this is really probably been the biggest, what I would call silver linings, because I think in particular for psychiatry, different than other areas of medicine, we don't necessarily need to lay hands on our patients, right? We can provide our services without having to see them physically. And so one of the things that happened very quickly was we were able to stand up not only telepsychiatry, but telepsychiatry in the patient's home. So pre-pandemic, we had some telepsychiatry. It was just a little bit more clunky and difficult. You had to go to a mental health center. Typically, you had to sit there with a nurse who sits you in front of the computer. It was just different, right? It was a little bit more burdensome. And now the ease with which patients can do it has really been a game changer for us. Now, what's going to happen? And just like Allison said, there was a ton of national and local response to that to get that up and going. And our hospital was like so quick. They were awesome in doing that. And going forward, it's still going, we still want it to be part of what we do because it's proven to be very beneficial, especially in that context when I showed you the graph. We want to serve all of Iowa. So one of the ways that we're able to do that is by telepsychiatry. There are some issues in the future with whether or not insurance companies are going to continue to pay us for that. So those are a little uncertain in terms of where we are right now. But for right now, it's a beautiful tool for us, and we're really happy to have it.
Great, thank you. Dr. Stevens, I wonder what suggestions you might have for families to help their children during this time of isolation and then as they re-enter into the school and social activities.
Yeah, I think that one of the really important things I didn't highlight is just how serious problems can get for youth and how much they can keep it to themselves. I want to communicate one of the most important things is to take the time to have a conversation with your young person and your family. One of the things people worry about is that if you have a conversation suggesting that someone would be depressed or anxious, or even at God forbid, have thoughts of not wanting to live, that this will put ideas in a person's head and make it more likely for them to have those kinds of thoughts. And actually, the opposite is true. Individuals feel much more relieved when they have the opportunity to talk about even the possibility that they have these thoughts. And they look at an inquiry into maybe the same old thing of like, oh, those adults doing their adults thing. But it makes young people feel supported to be able to have someone to talk to about those problems. So I think one of the most important things to do is to take the time to say, hey, a lot of things are going on right now. You've just had these big transitions, or you've had a lot of kids sick at your school, or, your favorite teacher has been quarantining. I just wanted to hear, like, if that's really been bothering you, what have you been thinking? It bothers me when things like that, you can give that example of the fact that it's okay, and normalize the fact that you can have responses to those kinds of stress. And then, even have that tough conversation of, I hope this has never happened to you, but some individuals feel like they don't want to go on living when things are really hard. I hope that hasn't happened, but if it did, I hope you'll talk to me about it. So that kind of frank conversation, I think, can be really, really important. And then if additional help is needed, we're going to be actually distributing some resources on online help and hotline help and other resources that people can access if things become more serious. But hopefully with that kind of inquiry, you can actually start to have that intervention happen at home and for kids to feel more emotionally supported.
Good, thank you so much. Dr. Lynch, I'm wondering what you have seen as the most impactful challenge in providing addiction medicine and care during the pandemic.
Yeah, I think it's really been the impact of social isolation and social distancing. There's a lot of different kind of models to understand what addiction is. And one model is that it's a disorder of loneliness and isolation. And many people will identify with the idea that they drink more or use more substances when they're lonely or by themselves. And often that doesn't feel like healthy use when using alone. And so in so many ways, we removed people's connection with each other and put them alone in their home or in their office and just kind of stripped them from all of their interactions. And like I said earlier, many people use mutual support groups like AA as a big part of their recovery system, and it allows them to connect with the people that they feel like they can talk to and ask for guidance and help and support, and to have that removed, that's really been, I think, one of the biggest challenges. There have been many, but the isolation has really been a big challenge for people.
Dr. Nopoulos, do you want to take some of the questions that have come in on the Q&A there?
Yeah. One of them, I think actually, Allison, that you were just talking about is how has the pandemic affected isolation and, people who are working from home in their careers. But another one related to that is, what about medical compliance? So compliance with medications. So has the pandemic affected med compliance for those that need assistance to prevent crisis?
Yeah, I mean, that's definitely been an issue. It's been harder for some people to get their medications. That's one issue. And then things like just having support or reminders from other people, or just reinforcement about the importance of continuing to take medication. Absolutely. I think that's been a part of it too. I will sort of shout out to our pharmacy, and I think a lot of pharmacies did this, mailing people their medications so that they don't have to come to the pharmacy has been a big convenience for some people, and I think made a difference to help them stay on their medications.
I also think too, so we had a grand rounds this week from one of our faculty members who does work in telehealth and e-health. And I think that there's just going to be more and more outreach to our patients. And she talked about a mechanism by which there is routine texting of patients to remind them to take their medications. And once again, I think once patients are a little bit more connected to, my chart, right? Because my chart is the mechanism by which you can do the telehealth. And I think that we're in for just a whole new set of novel ways that we can connect with our patients. And so I really like that small program that she was doing. It was actually through the VA, but it was texting patients on a regular basis so they could be reminded to take their medicines. Another one here, this information is shocking, especially the data regarding teens and younger people. How will we let people know? The problem cannot be solved until we know the size, scope, and complexity. So good to hear your support of telehealth. Hannah, do you want to make any suggestions of how we let this be known?
Wow, yeah, that's a big one. I mean, I have seen, really reassuringly, I think I've seen attention to mental health out in the press, out in the public domain, a lot more than we used to. And I think that there's been a growing trend even before the pandemic of normalization of mental health and seeking help. There have been high profile people who have come out saying that they have had struggles with mental health in the past, have overcome them with the appropriate supports, and not minimizing, but also not making it seem catastrophic and unhelpable. So I think that that's one of the answers to that question, is to have discussions that, just like we talk to our kids about washing their hands and making sure they're doing everything to avoid getting infected with this virus, we have to think about the fact that I think ordinary people have to talk to each other about, hey, you're masking up and you're doing the right things to take care of yourself in infectious disease. And what are you doing to take care of your mental health? Are you looking after yourself? Are you thinking about the things you need to think about? And also acknowledging that we ourselves have struggled, because the normalization can go a long way. I think that there are a lot of reassuringly, to the second part of the question, we do need to know the size, scope, and complexity of what things going on. There have been, along with some of the sort of influx of funding to support studying COVID and how it infects inflammation and the immune system and the lungs, there have been funded projects to look at the impact on people's mental health, both from the sort of short-term aspects of what has happened over this past year, but also to think about, are there going to be long-term sequelae? One of my interests, as Dr. Lynch had mentioned, is trying to think about how things that happen to our brains when we're very young actually have long-term impacts for our brains as they have to develop and grow after that point. And so there actually are funded projects out there to start examining the impacts of this kind of exposure to both the pandemic changes of lifestyle, but also the possibility that even if you recover from a COVID infection without any apparent impacts, are there long-term impacts in brain health and in many other health domains. So I think, supporting research funding for that kind of study is really, really important. We do some of that work here at the University of Iowa. It's funded also more broadly by the National Institutes of Health. And I think that that's all going to be very beneficial for knowing. I'm sure there's other things that could be said too, Dr. Lynch and Dr. Nopoulos.
Dr. Nopoulos, one of the things that we are reading about in the popular press, I just read an article yesterday, I think it was in the New Yorker, is about the impact of COVID treatment by healthcare workers, right? I mean, the kind of incredible stress that has been placed on healthcare workers. And I wonder if you could address what we're doing at the University of Iowa and what other things are happening to support the mental health of our frontline healthcare workers.
Yeah. So I must say that I was so proud of our hospital. Our hospital was on top of things. And people just came together. And this now seems like a long time ago, but right at the beginning when we shut down, we were already thinking about how to do this. And I'm also so proud specifically of our department, because one of the first things we did is we opened up a hotline specific to people in the hospital, our employees. Okay, we were already taking care of our patients, but this was very specific, and it was manned 24/7, and this was above and beyond. So our faculty signed up and volunteered for it. And that was a really important in the moment, and that lasted for several months. We also made sure that we had what we call facilitated access for our employees in particular. And so we advertised that, and I think what's hard is, Allison already mentioned it, is stigma. And so it was not only making sure that we had the services available, but we marketed and we told our colleagues, hey, it is totally appropriate for you to seek counseling, to see a psychiatrist. Here's the number. And here's the number again. And hey, how you doing? And so, like I said, we had the resources and the services, and I think it was really, really important. We talked about earlier, I think, with other chairs earlier today, about how there are other parts of the world and other parts of the United States that got hit, much harder than we did. That doesn't necessarily mean that the sting was less for us. We still had a ton of pressure, and our hospital still had a major complete turnaround from what we did to and I think someone else mentioned it, the ups and downs, when we had surges and not. And so it still continues. Things are indeed much better, that there is a little bit of heat off of us. But I think the next wave is going to be post-COVID syndrome. So we're seeing a lot of the brain effects that hit a large number of people. And this is really our second pandemic. Yeah. Is the brain effects that some people, that are potentially long lasting. And we need to learn about it. And we've already stood up a clinic for that. And that's going to include neuropsychologists and psychologists. And so we're looking forward to that.
That's great. Dr. Nopoulos, people often ask us how they can help, what they can do that would assist with these sorts of things, how they can make a difference. Can you tell us how people might be able to support and advocate for this work?
Sure. Well, one of the things is, we're going to have, so the links for the resources are going to be posted on the site for today's events, but also so we're going to have, and I'm sorry, I guess I need help with this, for the all access link is the www.foriowa.org. So that link is going to be available. But the resource page is going to be, if you need help, there's tons of resources. But also there's lots of ways to give in order for all of these services that we can grow, that we can dedicate to mental health, and in general, any kind of donations to help mental health in general are welcome and appreciated.
Well, thank you. The place to support the work is there in the chat function, and
there we go.
The resources yes. that we have been talking about are now up as well. I want to acknowledge the remarkable things that you have taught all of us today, and to thank Dr. Nopoulos and Dr. Stevens and Dr. Lynch for sharing your expertise with us. And we want you to know how proud we are of the work that you are doing and how grateful we are for the services that you provide. I also want to thank those of you who have taken time today to be with us. Our physicians have provided some resources for you that are listed on the screen. And if you are interested in providing philanthropic support, you can do so through that giving link that's provided in the chat. We look forward to welcoming you back to campus soon. If you haven't heard, we are planning on in-person classes this fall, and somebody even told me we're going to have football at Kinnick. So we would love to welcome all of you back to campus who are from far away, and we hope you have enjoyed learning a little bit more about these important programs in our Department of Psychiatry, and look forward to seeing you at other virtual events. Thank you so much. Take care and go Hawks.